Hi, I'm Desiree Chappell. Welcome to Top Med Talk. It's Tuesday and it's time for my Roundtable. The Roundtable is a chance to sit down with a multidisciplinary group to have discussion about perioperative care and improving the quality of what we do every day.
Top Med Talk.
My name is Desiree Chappell, host of the Roundtable, and we are joined today by Dr. Michael Scott. He's a professor of anesthesiology at Virginia Commonwealth University and also a professor at the University of Pennsylvania. We have with us Dr. Neil Seeley. He is the chief of anesthesia for the Cancer Treatment Centers of America. And Dr. Kevin Watkins, who is a surgical oncologist, also of Cancer Treatment Centers of America. Gentlemen, thank you so much for joining us this afternoon to sit down and have a good conversation about enhanced recovery for liver resections and just talking about where we've evolved. Dr. Scott, I know that you started 15 years ago with enhanced recovery in your practice for cancer patients. Can you give us a little bit of background about that? And then we'll talk to Dr. Seeley and Dr. Watkins about their experience in more recent years.
We started doing enhanced recovery back in about 2003, mainly concentrating on colorectal surgery. But what really drove enhanced recovery for us was not the short lengths of stay, it was actually the cancer outcomes. And because we collected the data and we had a national data set, we knew back in about 2009 that we were, for the same type of cancer and patient population, we were getting significantly improved cancer outcomes. This was multifactorial. We looked into it. It's both the fact that we had uncomplicated surgery, because we know complications can drive cancer, poor cancer outcome, but also we realised that we were sending our patients to mop up chemotherapy basically sooner. And also the other thing is we had very good results in our primary liver resections, and we published on that as well in the BJS, where we had one of the lowest morbidity, mortality, and yet it's still the lowest length of stay. So it is interesting that enhanced recovery in different ways can lead to actually affecting life expectancy and cancer outcomes, both directly and indirectly.
Dr. Seeley, when you were looking at enhanced recovery pathways for your patients, was this a piece of literature that you used, and how has that affected protocol development and actually implementation of enhanced recovery in your own practice?
Well, sure. The European literature really drove our practice. We looked at all the literature that had been developed many years ago in Europe and looked at what we could do then to jumpstart our program by replicating what had already been proven to be successful in Europe. The thing for an anesthesiologist that is such a wonderful feeling when we apply the enhanced recovery principles is that for once we can show that we can make a difference not just for the patient in the PACU, which used to be the territorial boundary of where we ended our concerns, and now we're seeing that we can affect the patient post-operatively in the whole post-operative period, and then, as Mike is suggesting, improving their outcome long-term. So it's exciting for me.
Yeah, absolutely. Dr. Watkins, what's been your experience coming from the surgical side? What's the difference that you've seen in your patients? How has it changed for you?
Well, there have been a lot of different things that you see in the patients in terms of their satisfaction with their recovery, their approach to it's basically their engagement in the process. The fear of surgery is a real thing for people beforehand, and the more time that you can put in with them prior to surgery and lead them through a process that's not quite as scary, they tend to be able to move on and move forward with their lives. We deal at a cancer center that treats just cancer. So our people are already sick for the vast majority. It's not a lot of people who are not chronically ill. And many of them are not going to go on to survive long term. Many will, but at the period of time, if we can minimally impact their quality of life and get them back to the normal daily activities, I think that's probably one of the biggest drivers for us for enhanced recovery, as well as getting back to other therapies that most of them are going to need.
Thanks, Dr. Watkins. And at the Cancer Treatment Center, have you guys looked at the long-term effect of survival rates and things like that and the impact of enhanced recovery? Have you been able to collect that data?
I'll turn that back over to Kevin, but we've been doing this for 4 years now. As we opened the center, we started many components of the enhanced recovery, and then we finally put together the entire package really just 2 years ago.
Oh, okay.
Mike,
There's an interesting paper last year by Gustafsson in World Journal of Surgery, and they basically showed the increased compliance with IRAS elements actually had a long-term effect. And when you look at it in for cancer patients, it's almost like adding a chemotherapy agent in. So it is quite profound, and I think in the next 5 years or so we'll see more and more data emerging that rapid, uncomplicated recovery is good for you.
Yeah. When we talk, speaking of specific elements, when we talk about cancer patients in particular and some of these big liver resections and big complicated procedures, what do you find are some of the elements that have the most impact for those patients?
I think prehabilitation, pre-optimization is key, and the biggest one, certainly for the livers, was pre-optimization of hemoglobin. And if we had anemic patients, we would work very hard giving them IV iron. We were cautious with EPO, but we would try and get them to a target hemoglobin we knew that they wouldn't need transfusing at on an average blood loss. The other interesting thing is we've just had a fantastic talk by Dan Sessler on the importance of hypotension and avoiding it. And yet, actually, we used to break the rules for liver resection because sometimes controlling the circulation and putting the patient into a dive, you would reduce the blood loss substantially. So it's all a risk-benefit at the time. By saving a unit of blood transfusion, that has more of a negative outcome on your patient than actually a small period of relative hypotension. So it's interesting. What do you think about that, Kevin?
Well, I think one of the big keys in liver surgery is minimizing blood loss. During the procedure, there's clear outcome studies that, especially for hepatocellular cancer, that after resection, if your blood loss is high, your mortality in the short term is definitely increased. We use techniques as well, like isomethylene hemodilution, to try to use the patient's own blood volume to give it back rather than transfusing them, because it's an important thing in terms of long-term as well as short-term outcome for them.
Yeah, and Kevin, you had mentioned to me when you look at the surgical field and you see a lot of blood loss, it's not necessarily the blood pressure that you're asking me to adjust, but to go to a zero CVP, essentially. Is that true in the liver?
Well, it's the lack in the hepatic venous system that there's any valves between there and the heart. So whatever the pressure on the right side of the heart that gets seen, you get that pressure back in the hepatic veins, and that's what leads to increased hemorrhage as you get through the hepatic venous system.
Right. So, Mike, what do you think? Is zero CVP the answer, but
exactly
maintain the blood
what
pressure?
We used to do. We used a combination of either an epidural or remifentanil to basically drop the venous tone. Mm-hmm. And we would although the patients were carb loaded, we'd give Lasix at the start, just 20 milligrams, so that by the time we're going into surgery, we were relatively hypovolemic, and we'd use phenylephrine to maintain stroke volume. Right. And then if there was bleeding, we'd ask whether it's arterial or venous, and then we'd either go into low pulse pressure anesthesia or low CVP anesthesia, or a combination of the two. Right. I think for that, hemodynamic monitoring is really vital, because otherwise you don't really know whether it's lack of venous return or true hypovolemia. Right. And certainly the bigger resections like cholangiocarcinoma I used to find very challenging, because they used to get very SIRSy. So those even more so you need the monitoring. Right.
And so we find that by doing the hemodilution early and not replacing it with 1-to-1 albumin or whatever your recipe usually is, but allowing for the hypovolemia, and we're using the stroke volume variation monitor, and we've come to believe that a stroke volume variation in the 20 range is equivalent to zero CVP. And then, of course, I look at Dr. Watkins and say, what do you see? Because that's the proof of the technique, is if he sees the flat.
And again, one of the keys to it, I think, is just to have the communication back and forth, so that, at the head of the table, what we're seeing in the operative field, because sometimes you may or may not be able to necessarily see it as I'm holding pressure on a venous bleed to control it, to try to get around it. So it's really just a matter of being able to have a conversation back and forth throughout the case.
Right. And that really is key. The nice thing about working at a small hospital is that we all know each other, and we have the same teams for Dr. Watkins' cases very routinely, so that makes a big difference in that kind of surgery.
Yeah, I support that. We had the same group of anesthesiologists giving the same anesthesia, and everyone knew where they were, right? And they knew the surgeons. We knew if the inflow was impaired, and we would say, and we'd tolerate it for X amount of minutes, and then if it was unbearable, then we'd ask someone to change.
Can you release it? And that's one nice thing about the enhanced recovery protocol, is that we have a very protocolized anesthesia. And so Dr. Watkins is not seeing somebody new, but also not a new technique. It's the same technique no matter who the anesthesiologist is in the room. So,
well, it's talking to reducing variability of
each
of the providers, and anybody can kind of step in and do it. And that's kind of the science of it. I can use my hemodynamic monitors to guide the way I'm treating this patient, but the art of it and the piece where I think enhanced recovery has really helped us is creating that conversation, and we can learn to communicate a little bit better and have better outcomes. One
of the interesting things in our papers when we drilled down into what made a difference, because even in our standard care we still had 12 ERAS elements, it was the rapidity of resuscitation once we finished resection, which was really important. The sooner you restored intravascular volume and mean arterial pressure, that group definitely did better. Whereas, and so if that was physician-led, or what it was with our two residents doing their PhD equivalents, so the more rapidly they restored that by being there, the patient did better. Whereas if you take them to the ICU, people are a little bit cautious about giving too much fluid too quickly.
Right.
And so you'd find that, yes, they would reach resuscitation where they needed to be, but it was always a little bit longer.
Right.
So I think it's always better to do it yourself, really, and make sure that the patient's back to normal volemia before you hand them over.
That's the beauty of the stroke volume variation monitor, is that it's instantaneous feedback on what amount of fluid to give them back. And so it has really made it easy to get that patient down to a 0 CVP, and when he no longer needs that control, to within 5 minutes be in normal volemia again.
And at the same time, we want them back to normal before we close, because the cut surface of the liver and the risk from hemorrhage, we used to see that, in some of the initial laparoscopic liver resection experiences, they used to see that because the insufflation pressures would tamponade the bleeding for a period of time, and then once you release it, it would go, you would get bleeding postoperatively, and it's the same thing.
Yeah, we actually, for the laparoscopic livers, would put them flat, let the gas out, give them 5 to 10 minutes, and then go again and have another look just to check there wasn't bleeding.
It's great. Well, gentlemen, thank you so much for spending time with us this afternoon. I think we had a great conversation.
Thank you, Desiree.
About
thank you for hosting
another service line that we can talk about, enhanced recovery.
Right.
Been around for a while, but we're still refining the process. Thank you so much, and have a great rest of the meeting.
Thank you very much.
Top Med Talk. Nick Majerison here. Thank you for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.